defines obesity as a chronic relapsing disease. So it's not just the habitus, but it's a disease process in its own merit, where there is excessive adiposity in places where it is routinely found, or in places where it is not supposed to be found, and that causing impairment in health situations. The Endocrine Society of India has defined obesity as a chronic, relapsing, progressive disease. So it's a CPR situation, the chronic, progressive, and relapsing disease defined by excessive fat deposition, which impairs health as such. This therefore should follow the approach that is followed for any chronic illness, like start initiating interventions and keep modulating these interventions, sometimes hiking up, sometimes low. So whatever in time there is a need for a goal to be achieved, that is met. So it is just not a cosmetic appeal and a concern. It's a serious metabolic and medical problem, which in turn accelerates the risk of any other disease process as well. The usual parameter which we use to measure obesity is body mass index. So it increases the type 2 diabetes, heart health, disease, bone health, the difficulties, as well as certain cancers. It also reduces the quality of life, including sleep processes and mobility. BMI varies according to age and gender in infants, children, and adolescents, and also according to demographics. Apart from BMI being an important determinant of the health consequences of obesity, we are now moving on to weight-to-hip ratio, which is a crucial clinical parameter for assessing the impact of obesity on health. So, for women, a WHR of 0.85 or higher is considered indicative of abdominal obesity. The more the waist circumference, the more the risk of visceral fat, the more the risk of central obesity, therefore higher health implications because of the obesity itself. Can we please mute others, because I'm kind of hearing echoes and not able to see. Thank you. And we know that just not BMI, but a higher waist-hip circumference ratio is also associated independently with an increased risk of type 2 diabetes, cardiovascular disease, and hypertension. So in a nutshell, obesity itself is a metabolic syndrome affecting end organ in multiple organ systems as the weight increases, leading on to various end organ affliction and in general multi-organ failure in the long run. So, what are the obesity indicators which are used in various age groups, and how do we make any interpretation out of them? When the body mass index is more than 25 kg per meter square, it is obesity. In Asian women, it will drop down to 23. Waist circumference more than 80 centimeter is women. Waist hip ratio of more than 0.8 in women, and a body fat percentage, that's the difference between men and women, because 30% of fat and more than 30% of fat as the body fat percentage in women is indicative of a higher risk with regards to the problem of obesity. Whether it depends on the children or the adults, definitely obesity in younger children, if the BMI is more than 95th percentile of their age, then it is definitely associated with higher risk of metabolic complications as well. So, why does obesity in fact happen? There is a mismatch between the calories we consume and the calories we expend, and therefore there is a positive balance of the fuel or the nutrition we take in and the excess is deposited as fat in normal areas in excess or in abdominal areas in excess. So our body is evolutionarily trained to store excess calories as fat in adipose tissue, which is an instinctive survival strategy as part of the evolution through which we have come through. So obviously, increased intake of calories will be converted to fat if not expended and will be stored in the adipose tissue. So for adults, WHO defines overweight and obesity as follows. Overweight is a BMI greater than or equal to 25. Obesity is a BMI greater than or equal to 30. For children, age needs to be considered when defining overweight and obesity. Let us look at the change, because nowadays I see younger girls between the age of 13 and 18 coming with a weight of 90 plus kilograms. So how do we define that? For children under age of 5 years, you calculate the weight for height. If it's greater than 2 standard deviations, then the child is overweight. You again calculate the weight for height, and if it's more than 3 standard deviations, that is obesity in children under 5 years. So no more your calendar Butter Krishna is the iconic image you want your child to look like, because obviously that is one type of malnourishment, and the child is at higher risk of developing adulthood obesity and further developing complications related to obesity. Children aged between 5 and 19 years, overweight is BMI for age greater than 1 standard deviation, and obesity is greater than 2 standard deviations above the growth reference period, which is very, very important to understand, because nowadays we see all teenage groups with severe PCOS, nutritional problems in terms of obesity, early onset prediabetes, as well as menstrual problems and body image disorders with mental health afflictions as well. So what are the various systems which are affected by the higher risk of obesity, and what could we potentially prevent if that is the case? As you can see, the nature of the fat deposition is ubiquitous, and so is the affliction of the various organ systems. The cardiometabolic syndrome converts itself to having diabetes, dyslipidemia, hypertension, and therefore metabolic syndrome. The non-alcoholic fatty liver disease, now known as metabolic associated steatic hepatosis, or MASH nowadays, which is non-alcoholic but metabolic. Various gynecological abnormalities in women, abnormal periods, dysfunctional uterine feeding, or nowadays we call it as abnormal uterine feeding, fertility reduction, polycystic ovarian syndrome, hirsutism, incontinence, both overactive bladder relating to urge incontinence as well as stress incontinence, osteoarthritis, gout because of hyperuricemia, which is again an indicator of metabolic syndrome. In the lung department, we do have obstructive sleep apnea and hypoventilation, body image causing depression, GERD, so many factors which can be potentially prevented if we concentrate on reduction of body weight. So this is further more complicated in Asian or Latin Indians, where there is a unique feature of obesity, that they have a body habitus called TOFI, TOFI, thin on the outside, fat on the inside. So just by being thin, it doesn't mean they are healthy individuals. They are thin because their lean muscle mass is reduced, but their visceral adiposity or central adiposity is excess. So they are typically characterized by having thin extremities, excess body fat, abdominal obesity, increased visceral fat, and deposition of the fat in ectopic sites such as the liver or the muscle. This classically happens when somebody doesn't exercise and have got higher calorie intake. There are people who come and ask us, I'm thin and I can eat anything. I don't need to exercise. I will
Sugar,
still put on weight in the tummy. And that's the reason, because they call it the TOFI habitus, which is even more dangerous than the obese patient, because it's very hard to make them understand why toffee is unhealthy in the long run. I just wanted to project this particular graph to demonstrate the fact that both rural, urban, and in general, the national picture of projecting the rate of obesity 20 years from now is linearly increasing, both in the rural population, national population, as well as in the urban population. Every 10 years, we see a linear increase in the proportion of overweight adults as well as obese adults in the long run. This is the forecasted picture, which is going to look like with regards to the obesity. As you can see, the pink line will denote the higher range of obesity in these countries. This is to demonstrate in a large study from about 700,000 patients of understanding the distribution of abdominal obesity depending upon the weight of the participants. So if you took a normal weight cohort, 50% and more slightly had abdominal obesity. If you're underweight, only 34% had obesity, abdominally fat obesity. If you were overweight or obese, more than 65% had abdominal obesity, and nearly 75% in the obesity group had visceral and abdominal obesity, which is far more dangerous high-risk marker to predict the onset of metabolic syndrome and the end organ complications. So just BMI alone is not a prognostic marker or a clinical indicator of the metabolic severity of weight-related issues. It is actually the waist circumference and the waist to hip circumference ratio. As you can see, because the abdominal obesity is higher in the overweight and the abdominal in the obese population. This is again to give us a representative factor of the presence of obesity in general and the presence of abdominal obesity in our population. I want you to see the first table, and you can see in college and higher and the female population, you can see the prevalence of obesity is 15 to 20%, which means 1/4 of our women are obese, and they are all young adults. But in that obese population, 60% have central obesity or visceral obesity. That's a huge proportion. However, in the second table down below, there is no big difference in the presence of any variation between where you live, whether you're living east, north, south, west. There's no difference in the population demographic distribution of obesity or central obesity. So this is very important for us to target our policy as well as awareness programs among people as to why waist to hip circumference ratio is important. We now need to find out how are we going to prevent the consequences of obesity and obesity itself. So we adopt the typical community medicine strategies of primordial, primary, secondary, and tertiary prevention. When there are subclinical obesity risk factors like biochemical parameters, when there is a slightly increasing fasting blood sugar trend, when there are physical symptoms, psychopathological symptoms like dysmorphic body image disorder, and functional limitations, then we start off on the primordial prevention methods and identify the risk factors and encourage healthy eating and physical activity right from a young age. When there is an established obesity, then we start with behavioral therapy with supportive medication therapy for correcting any biological abnormalities and associated comorbidities like pre-diabetes. When there is an end organ damage or there is a significant functional limitations or well-being being impaired, then we go on to completely medical therapy, and to a certain extent for somebody with a target, we also can advise bariatric surgery. When there are severe disabilities, disabling psychopathological situations or functional limitations that we have to advise bariatric surgery. However, with an intent to continue any kind of behavioral therapy, lifestyle modification, and risk factor reduction in these patients, even if they have had bariatric surgery, because the weight loss which happens as a result of the surgical intervention, if we do not address the risk factor reduction or the lifestyle changes, the weight gain post the bariatric surgery also is known to occur, nullifying any benefit conferred to the patient as a result of the bariatric surgery. So why obesity happens? Is there a genetic predisposition? Yes. Certain patients have a slow metabolic rate, which is again determined by age, ethnicity, or other endocrinopathies like your thyroid deficiency, and certain medications, sarcopenia, which is muscle loss, or a recent weight loss, and genetic makeup of the patient itself. Some are known to have a high calorie intake because of the social-cultural environment they live in. We all celebrate everything with food. Food is considered as comfort, food is considered as a notion of joy, food is considered as an element of sharing, food is considered a part of our tradition as celebration. So people resort to food and every time there is an occasion of joy, sharing, or celebration. So it's kind of inculcated in the culture to have excess calorie intake in terms of sweets or high fatty substances. And this over time leads on to an emotional eating which is related to the discomfort which is being given by the food and the memories which come with that comfort. So it forms a vicious cycle and goes to a further increased calorie intake. Decreased physical activity because of social-cultural environment, surrounding environment. Now people live in high-rise buildings. They don't go out and play right from childhood. Everything is gadget related, and there are emotional factors and physical limitations and further other genetic predispositions. We also know obesity is linked to multiple cancers and increases the risk of these cancers in about 30 odd cancers as an independent risk factor. So by reducing obesity, we reduce our lifetime risk of these 30 odd cancers significantly. The other important aspect nowadays, which is spoken about in obesity, is the effect on the gut microbiome. Now, everything is all about gut microbiome. You have a healthy gut microbiome, you can ward off many inflammatory autoimmune problems in the long run and reduce the implication of those problems as well. This is just to give you an idea how obesity influences the microbiome. If you have a normal non-obese patient, the gut flora is always about increased diversity and stability. There are a group of bacteria which keep the balance right with number of good bacteria. The tight junction integrity is increased and well maintained. Short chain fatty acids production is also increased. This increases insulin sensitivity and receptivity and increases the immunity, but reduces inflammation and keeps a balanced microbiome. Whereas, if you have obese patients, there are more fermenting bacteria there, more gram-negative bacteria there. There is a reduced diversity, more pathogenic bacteria, less lactose fermenters, and because of that, lipopolysaccharides are increased, which suggest the gram-negative bacteria more. That causes inflammation of the gut. The tight junction integrity is compromised to the gut, and thereby leaky gut syndrome happens, more insulin resistance, more adiposity, and lesser insulin sensitivity. This further works on the enterohepatic circulation, more triglycerides, more fat deposition in the liver, causing a dysbiotic microbiome. This is how the pathogenesis of obesity and its metabolic implications from the enterohepatic circulation and further causing deposition of fat in the liver as well as an implication in cardiovascular disease. This is how it happens. It is also related to mitochondrial dysfunction, and that is why there is increased oxidoreductive stress, more adipogenesis, more inflammation. In general, if we remember, obesity is a pro-inflammatory status. Because of the pro-inflammatory status, there is furthermore cortisol. Because of that, furthermore lipogenesis, furthermore gluconeogenesis, further insulin resistance, and it goes in a vicious cycle of impaired glucose, impaired fat deposition, and further metabolic syndrome and its consequences. What is the relation between obesity and obstructive sleep apnea? Obesity definitely because of the neck fat tissue, short neck, and swelling of the tongue or edema of the tongue or the thickness of the tongue causes falling back of the tongue, causes obstructive sleep apnea, which causes intermittent subclinical and clinical hypoxia, and thereby further increases the intracranial pressure, causing hypertension, increased incidence of stroke, increased incidence of idiopathic intracranial hypertension, non-pressured hydrocephalus, and serious morbidity as well. This is crucial because one of the important aspects of OSA is to try and reduce weight, and which will further improve the consequence which has been there with the OSA. What about obesity and fertility in women? It definitely impairs early follicle development, thereby reducing the follicle development and causing atresia, has an inhibiting effect on the endometrial receptivity to the embryo, increases the inflammation and thereby causes higher risk of miscarriage. Because of the insulin resistance can cause anovulation and reduce sex hormone binding problems, thereby causing more androgen production. More androgen production can cause even more hirsutism and further suppression of ovulation, and thereby sets off a vicious cycle of hormonal imbalance, which leads to serious metabolic consequences. Therefore, I always insist when we see a patient of PCOS in a young adolescent and adult age group, it's about making them aware and educating about healthy lifestyle practices which will prevent or procrastinate the metabolic syndrome and the metabolic consequences, and never with an intent to enhance fertility or prevent fertility deterioration in the long run. The reason behind this, the logic behind this is, if I were to address the root cause of the problem, i.e. the obesity and the pro-inflammatory status, I will automatically improve the insulin resistance, automatically improve the sex hormone imbalance, and thereby the consequences thereupon on the reproductive system, such as anovulation and fertility reduction. So focus on the metabolic implications of obesity and PCOS rather than just the fertility aspect of it. With regards to obesity and pregnancy, it is definitely a challenge. Nowadays, we're getting more patients with BMI of more than 40. It poses a huge risk for pregnant women, especially highest incidence of gestational diabetes, requiring buckets of insulin to control macrosomia, then leading to increased risk of cesarean sections and birth trauma. It can be a prothrombotic status, leading on to higher risk of DVT, higher incidence of preeclampsia, HELLP syndrome due to the pro-inflammatory status of obesity in pregnancy, higher risk of fatty liver and gallbladder disease, which can get complicated during pregnancy, such posing a serious challenge of medical disorder complicating pregnancy. So how do we train then with regards to weight optimization program? We need to make a thorough assessment of the severity of the obesity, we need to do a first phase, intense weight loss phase, then weight loss maintenance phase, and then weight gain, regain prevention. Most of the patients stop after the intense weight loss intervention phase, and once they stop it, they are not able to maintain, in fact, regain whatever they have put on within a matter of 2 months and get demoralized or defunct with the process. So the level of therapy should continue about revisiting these techniques, the dietary implications, the importance of physical activity, more so in the maintenance phase to prevent the weight regain. That is what is most important. As I already mentioned, we know body mass index, waist circumference, waist to hip ratio, and we also measure the skin fold thickness in the triceps area, the back of your arm, to find out subcutaneous fat. We clinically then correlate on the image-based obesity indicators with our DEXA scan, which shows the whole body lean muscle mass and whole body fat deposition percentage, and we can differentiate how important the abdominal obesity is with regards to the features of weight gain. This is just to tell you the various stages of the weight gain as well as obesity in a severe form, and what are the various implications and therapy measures we have with regards to treating the obesity. So the treatment approaches initially will be to have lifestyle as the prima facie cornerstone treatment. It manages the medical nutrition therapy, it addresses the behavioral changes as well as the fitness exercise regime which is needed. The nutrition concepts are low carbs, low fat, and intermittent fasting with multidisciplinary weight loss programs. And support is being offered either by digital tools or apps or any continuous monitoring which you can do with gadgets, so that there is accountability as well as objectivity to what you're eating, what you're exercising, and what impact it has on the body habitus as well as the biological or biochemical parameters. There are various formulary diets which are meal replacement. We need to address these in the intense phase, but the maintenance phase has to be maintained with lifestyle healthy choices. And when I say lifestyle healthy choices, they last for life, and it is not just for a single episode or a single period of time. We also now have drugs which are, I'm going to elaborate, and finally we have the bariatric surgical procedure. I'm going to touch upon these medications because now we get a lot of queries about the usage of Wegovy or Ozempic, which is the semaglutide, and the liraglutide, which had been there as Victoza. We don't get it now in the Indian market. The Wegovy, the Ozempic, or the semaglutide, which has been marketed as Rybelsus medication, which is orally available. It's a GLP-1 receptor agonist. It's basically works as an adjunct. I want to emphasize on this. It is not in separate. It works as an adjunct to a reduced calorie diet, increased physical activity. So these two are must in any form of therapy which we initiate and maintain. Without these two pillars of reduced calorie intake and increased physical activity, none of these medications are going to cause a visual impact or visible change in the weight or the parameters. And it has to be done once weekly, and we can escalate the dosage, and on the same day each week at any time of day without meals. Many people find it extremely tiring, have abdominal symptoms, flatulence, hypoglycemia, GERD, and gastroenteritis, especially if they are not taking the right type of food and indulging on a high sugar diet. Similarly, liraglutide, we have the other one which is topiramate extended release, which is an adjunct again. This is a symptomatic which affects the appetite and basically can cause constipation, dry mouth, distaste, etc., etc. We do have Orlistat, which we have marketed as Venicol in the past, as well as Reshape. It is a lipase inhibitor. stuff. So basically reduces the absorption of fat in the gut. And it is important for rapid weight loss in some people and reduction of risk for weight loss regain after the prior weight loss as well. But one of the most important things, you need to take it with the meal or within an hour after the meal. And if you take the wrong type of food, especially fatty foods or fat-rich foods, you will have steatoria, which is escape of fat in the stools, with oil-like stools which will be there, extremely flatulent fecal urgency, oily evacuation, and fecal incontinence as well sometimes. So many people do not take to it very easily, and you have to be very careful with your diet and not indulge in certain treats, because this will be very disturbing with regards to flatulence as well as steatoria. There are phentermine which have been used as symptomatic and reduces the appetite aspect of this and thereby useful in certain weight reduction programs. However, a serious complication of primary pulmonary hypertension as well as multiple various cardiovascular unpleasant side effects are known, that's why it does not have its repute as an important weight management medication. So in general, we have the semaglutide or the liraglutide, and we have orlistat, which are very effective anti-obesity medication. What about medical nutritional therapy? We have the 7 A's principle, which is very, very important for medical nutrition therapy, and this is for life. It should be accessible. It's not something you always have to order online. You just walk into a grocery store, you should be able to get it. It should be acceptable, so work with what your cultural and traditional practices are. Millets, brown rice are a good substitute to keep medical nutrition therapy in place, because these are acceptable, these are available, and these are easily accessible. It should be accurate. Use your measuring spoons. A katori can be this size, katori can be this size. So a measuring cup for a lady will be perfect. Absorbable. It should not cause any GI symptoms. As I said, it should be affordable. It should not be so highly priced, like whatever they brand it as organic being super pricey, then it is bound to be non-compliant. It should also be attractive and appropriate for your cultural practices and your family. That is very, very important. I also want you to concentrate on the plate model which we have shown. If you are able to keep your plate as simple as this, we do not go shopping for lipids. We do not go shopping for proteins or carbohydrates. We look for these kind of food groups. So we look for whole grains. We look for healthy protein, which is plant-based protein. Fish and egg are the choice of protein if you're having animal food, fruits and vegetables. So shop according to your food groups. Populate your plate the way we have shown it in the legend. That is healthy eating enough. Restrict your dairy intake to 2 cups, not more than 2 cups. Restrict your oil intake. Use combination of oils. Do not use only refined and seed oils. These are more pro-inflammatory as they increase the trans fat, and limit your saturated fats and animal fats like ghee or butter. These are the various surgeries which are recommended for the weight loss program. As I said, gastric banding, sleeve gastrectomy, Roux bypass. The Roux bypass is more long-lasting but has significant major complication rate, and diversion surgeries. As you can see, the target weight loss can be anything between 35 to 40%. However, they have very strong metabolic effects, can lead on to nutritional deficiencies, especially vitamin B12 deficiency, and durable weight loss is also known to happen. They can only eat little amounts and they go into complications such as dumping syndrome. We have intragastric balloon, one anastomosis gastric bypass, aspiration therapy, vagal nerve blocking therapy, so on and so forth are multiple interventions which are used for weight management. However, we have to understand which one is minimal access, which one is not, and how much weight loss can one expect. Having said all this, the caveat is these are for the rapid weight loss in a patient with metabolic or end organ damage as a result of the weight. To keep the weight loss and to prevent weight regain, we still need to continue a low fat, low calorie diet and increased physical activity, and that is the bottom line. Dietary strategies of weight loss, these are the various types of diets which are mentioned, but as far as I can see, after the initial phase of 4 to 6 weeks, if we adopt Late as a dictum of making sure you're eating the right nutrition of the right food groups in right proportion, it's all about portion sizes and the food groups to which will determine whether you have a balanced nutrition, avoid nutritional deficiency. As you can see, if you're going on a very low calorie diet, it can lead on to nutritional deficiencies in the long run and even muscle loss in the long run. So it has been known that Mediterranean diet is helpful in improving cardiometabolic parameters as well as longevity. And now with the intermittent fasting, it has definitely improved the weight loss which can happen with regards to obese patients. Now, I wouldn't call it intermittent fasting, I would call it time restricted eating. So you are allowed a feeding window within a day of about 8 to 10 hours, during which you finish all your meals and fast for nearly 16 to 18 hours a day. The dictum is you try and finish your meal as early as 7:30 in the night, whatever meal you have to take, and leave a full gap of 16 to 18 hours till midday the next day. That would be an ideal time restricted eating. Eating at 11 p.m. a dinner and then subsequently intermittent fasting till late evening may be okay, but it is not a healthy type of time restricted eating, because the last meal in the day is pushed very late and it is not metabolically healthy in the long run. So it is very important for us to understand. This is again the same picture which I have put with the daily as well. If we stick to the plate, this is how you plate your portions. If we stick to this, I think the weight gain will be prevented as well. So prevention of obesity as a principle, we need to increase our vegetable and fruit intake, reduce sugar and fat intake. For that matter, anything which has processed material in it, reduce it, increase the physical activity, better to have open air gyms and increase exercise, walking areas and sports facility and lung spaces. Each one has certain pragmatic targets, so motivation interview, social media messaging, digital therapeutics, app-based monitoring, as well as support group maintenance will all go a long way in our individuals coming together as a group, trying to increase their physical activity, staying connected, helping them to manage stress better and prevent substance abuse as well, which will further further reduce the chance of weight gain as well as the benefits of weight loss. So what are the future areas of research? We have a lot to do in terms of prevention, pharmacological management, as well as non-pharmacological management, the role of various dietary regimes, as well as physical activity combinations, which is better, whether it's strength training or cardio or only cardio. These will be helpful for us to look at the long run. And it's a patient-centric advice. It is not like one will work for everybody. Each one's metabolism is different. One thing we need to discourage is completely starving, because starving, if they continue to do that, that itself reduces the basal metabolic rate and their weight loss can become a challenge. Sleep is underestimated. Good sleep is essential for reduced inflammation in the body, and expected weight loss will then happen. Thank you. In a nutshell, obesity is not just a cosmetic appeal disease. It is a metabolic syndrome. It causes far-reaching consequences on various end organ systems. Medical nutrition therapy with reduced calorie intake, increased physical activity is the key for rapid weight loss and maintenance of the weight loss. Medical therapy in terms of medications can help with the accelerated weight loss. Surgery is reserved for people with end organ damage or significant disability as a result of their weight. However, to reduce the nutritional complications, medical nutrition therapy has to be continued for lifelong, and the mind plate method, plating your food groups, is the best way as a visual guide to know whether you're having the balanced nutrition in the right portion. Thank you.